Hello everyone. Today we'll be talking about an important aspect in the human body, that is the skull base. So skull base is quite complex area in the human body, which is dealt with a multi-speciality approach. Usually it involves the neurosurgery team and the ENT team, and it deals with a lot of diseases around the skull base. It can be tumors including benign or non-cancerous tumors or cancerous tumors, up to congenital abnormalities or leaks in the skull base, which is known as CSF leak. So today I'll just introduce myself. I'm Dr. Sachin, consultant neurosurgery. We have with us Dr. Satish Satyanarayana, senior consultant neurosurgery, and Dr. Satish Nair, senior consultant ENT surgery. So we will be briefing you about the complexity of the skull base and how we go about it. And I would request Dr. Satish to talk about an introduction into skull base, sir.
Thank you, Dr. Sachin. So, as Dr. Sachin rightly said, skull base is an area where the one specialty like neurosurgery starts and ends, and ENT also begins and ends. So, base of the skull is that area which traditionally has been called as no man's land, because one is the rarity of the diseases which have to be dealt with there, but at the same time the complexity of the problems that are encountered. Generally, we discuss skull base as anterior skull base, which is the front, and then the lateral skull base, which is the side part of the skull. So, there are different pathologies which occur in both these areas. Some of them are very unique. For example, the pituitary tumors, which are one of the most common benign brain tumors, which is second only to meningiomas in terms of occurrence, is very much a part of the anterior skull base, and it is something which we have always been doing through the nose. But what has recently been changed and which has really changed the way we practice tumors of the skull base approach is that there is a lot of advancement in technology. For example, in terms of, dealing with pituitary tumors, we use the endoscopes. So through the normal nasal passages, we will be able to approach the tumor in a very minimally invasive way, and therefore the surgery is much safer, the outcomes are better, the patient's recovery is faster, and many times the patients are surprised that after such a big surgery, by third day they'll be able to actually go home. Second, third day they'll be able to go home if there are no major issues pending. So the specialty has grown because of the one is advancement of technology, our own understanding of the anatomy, and microsurgical anatomy has evolved over a period of time, and we are able to understand those diseases better because we have much more sophisticated technologies in order to detect them at an early stage. So the MRI imaging, the CT imaging, etc., which are the backbone of diagnostic evaluation, gives us a window into these diseases at a very much earlier time, provided the patient actually comes to the physician to see at the very beginning of their symptoms rather than at a very late stage. So to start with, we will discuss common pathologies of the anterior skull base, and before we do that, I would request Dr. Satish Nair to also give a briefing from an ENT perspective as to what we deal with in the anterior skull base. Dr. Nair.
Thank you. So, as they said, the skull base is an area between the brain and below. So, the floor of this brain, that's where it is. So, traditionally, as we used to all approach that area, and if there's anything in that area, through an open approach. About 3 to 4 decades back, endoscopic nasal surgery started getting popular, and we kept doing bigger surgeries for the nasal cavity like sinusitis and etc. And then we found that yes, there is an area which is just above it, that is the base of the skull. So, any lesions in these areas which require to be treated combined in a combined approach could be treated through the nose. That's where the endoscope came in, and the use of endoscope allows, like you said, a minimal approach in which there's less amount of morbidity to the patient, less amount of trauma to the tissues. We are also able to reach exactly the place where we need to go, open up those areas and remove the disease. Also, there has been some amount of improvement in the way we can reconstruct them. Earlier, the issue was how to close this defect once we do that. Now, we have very good flaps, like vascularized flaps, which can be used from the nose itself, which helps in closing these defects. So, we can go in there. It's not a single process. It's a double, we call a 4-handed procedure. For example, 2 hands of the neurosurgeon, 2 hands of the ENT surgeon. So 4 hands are being used together, 4 instruments are going in through the nostril. One would be the endoscope, one would be the suction, one would be other instruments through which these tissues are removed, the tumor or the pathology is removed, and it can be reconstructed back with the patient being able to almost walk out within 2 to 3 days, which was never known, because earlier any surgical aspect in these areas, difficult areas, would take an open approach, a lot of morbidity to the patient, and also patient would be in the hospital for a long time. So giving a minimal approach and also giving a maximal clearance of the disease is what this endoscopic skull-base approach actually brings in. So as you said, the anterior one is through the nose that we go in, and lateral is one more through the ears or around the ear, that's the area to the brain and the skull base. So as you said, the most common one being the most commonest one being the pituitary is the area that we touch upon. So pituitary adenomas are very common, and Sachin, you would like to tell us something more about pituitary?
So pituitary adenoma is an anterior skull-based lesion which usually occurs in the area of pituitary fossa, and usually we see benign tumors, that is non-cancerous tumors, which occur from the pituitary gland. So pituitary gland is a very important gland which controls most of the body functions through production of various hormones in the body. Therefore, when there is a tumor which occurs at this area, most of which are non-functional tumors. Non-functioning means they don't produce any hormones, and usually patients present with symptoms because of the pressure of the tumor which compresses the surrounding structures, especially the optic apparatus. The optic apparatus meaning the eyes, the eye nerves which are very close or go above this pituitary gland, and when the tumor expands, the patients usually present with deterioration in the vision. They usually have complaints of inability to see in the lateral aspect or the sides, or the vision is very much narrowed, or there is a blurring of vision. These are some of the symptoms which they present with. They can also present with headaches, especially when there is a sudden bleed in the tumor, they can have a severe headache. And of course, when the pituitary tumors produce hormones, they can have impairment in the hormones, and that can have in fact impairment in the functions of the body. For example, they can present with lacturia or galacturia, production of milk from the breast when even they are not pregnant because of the variation in the hormone production. There can be thickening of the skin when the cortisol hormone is in excess, and there can be enlargement of the facial structures. If the patients can notice, for example, over a period of time, the pictures, there is was significant difference. So these are some of the symptoms with which they can present to the ENT clinic or the neurosurgery clinic, or in fact the skull-based clinic. So when they present with such symptoms, we usually investigate with the MRI or CT scan and then further proceed. So are there any other common lesions, sir, which occur in the anterior skull base apart from pituitary, which usually commonly present?
Yeah, so the most common is pituitary tumors, and conventionally, as Dr. Satish Nair rightly said, we used to approach these from transcranial approaches. Now, transcranial by definition means we are opening the skull, a part of the skull bone is removed, and then we have to go underneath the brain or between two lobes of the brain in order to reach it. So this kind of manipulation invariably happens if we do a transcranial surgery, and therefore, however minimal it is, there is a certain chance of morbidity, which has been quite low of late, but then still, if it is avoidable, that is the best way. So that is the reason why these transnasal approaches, through the normal nasal passages, you pass very thin endoscopes, and then we have certain working instruments which will help us to remove these tumors very safely. In fact, there is also an advancement in our diagnostics, and which can be directly applied at surgery, which is called as neuronavigation. Now, because of this neuronavigation, it is possible to entirely reach the area and also to know exactly where we are. It is like a GPRS system for the human body. Now, these kind of advancements will make it quite safe for the surgery. Now, after we have discussed about pituitary tumors, there are other classes of tumors which are also benign, and certain other pathologies which also can be entirely treated. For example, there is a condition called as spontaneous CSF rhinorrhea. Now, spontaneous CSF rhinorrhea means there is a certain defect in the skull base, in the front of the skull base, where the bone is very thin, and here either because of some long-standing back trauma or without any particular reason, there could be a leak of the brain fluid through the nose, and through the nose the patient will notice dripping of water-like fluid. Now initially this will be very confusing to the patient, but if they didn't have a cold or any rhinitis, and still if they had this kind of a leak, then they would realize that this is something abnormal and reach the doctors. So here we will be able to, through our imaging various advances, we will be able to detect exactly where this leak is occurring, and this leak can very effectively be repaired by this transnasal route. Going forwards, the next complexity is actual tumors which actually come at the skull base called as meningiomas. Now these tumors arise from the covering of the brain. Some of them arise at the top of the brain or sides of the brain, which therefore will require a direct surgical approach. But some of them are just at the level where the pituitary fossa is, or the pituitary tumors are, or just even in front of it. Here typically these patients present with a difficulty in vision because they are again close to the optic apparatus and optic nerves. They can be involved, either one or two of them can be involved. And here, when imaging is done, quite often 90% of the time we'll be able to confidently say that it is a benign tumor and that it is a meningioma. Some of these are actually, if they are not very large and very advanced, they could be tackled through the nose. So this is something which we have developed here, and this is like amongst the difficult frontiers in skull base surgery, because this requires very experienced surgeons to be tackling it, because one will be working in a very small space and with very limited accessibility, but we will be removing a much bigger tumor. So the technology standards involved for this kind of surgery and the expertise of the team is extremely important, and as well as the case selection. So many times it may be possible that it is not suitable for this, in which case therefore we opt for a transcranial surgery. So herein comes the concept of the skull base clinic, where it is a multidisciplinary thing, where we regularly meet and discuss every case which is suitable for in which particular approach and in which way it has to be done. So this is something which we have just started as the Apollo Skull Base and Pituitary Clinic, and this also involves an endocrinologist to be part of it. So Dr. Satish Nair will just highlight a little bit more about this workings of the clinic and how it will benefit the patients also.
So the idea was to bringing out this specialized clinic was to tell the patients and the public in large about what these tumors are, how they can be evaluated. It's not just about a single person evaluating and deciding on a surgery. It's about a team of people. Like it was aptly said before, that some of these tumors may have hormonal effects also. So an endocrinologist is definitely a part of it. He evaluates the patient about the various hormones, the pituitary hormones or others that are required, and decides if a medical management is required or if a surgical treatment is required for the tumor. Secondly, a most important cog in this whole thing is a neuroradiologist. So we also have a neuroradiologist who is specialized in these areas to identify, and who can, in a lot of positivity by seeing the scans, and give us a definite idea of what the lesion is, what kind of a tumor is it. Is it a tumor? Is it a benign condition? Is it a malignant condition? He can also actually opine to us and give us a roadmap for the surgery. In addition to that, the equipment is an important part of the whole surgical process that we have. As it is already told to you about the various advances, the endoscopes, the better processors, the cameras, the neuro navigation that is available, the other materials that are, and the specialized instruments that are required to do this surgery. In addition to all this, these clinics that we have would be held almost every day, where the specific cases would require a decision, a particular decision on what kind of, whether the patient requires a medical management or a surgical management, and if requires a surgical management, whether it's going to be a transnasal endoscopic or does it require an open approach in the skull base will be decided. So the team gets together, decides on case to case basis, gives a personalized approach to each and every patient so that the maximum benefit goes to the patient. So it's not just about performing it in a particular manner, but it's also giving the maximum benefit that is required to the patient, because after all, it is the patient that who needs to be, getting the advantage of this clinic.
So what are the recent advances in the surgical approaches? We use the latest techniques and how it will help the patient in the outcome.
So we just touched upon the diagnostics which have enormously improved. Now we have 3 Tesla MRIs which are able to track down even up to a sub-millimeter level the lesion, the extent of the lesion, the likelihood of what that lesion would be, etc. And also it is possible to, with the modern diagnostics, we can detect the leaks, exactly where the leak is coming from. Sometimes we will have to inject a dye into the subarachnoid space, into the spine, which will then be traversing into the skull base, and from there we can actually see the site of the leak. So with these advancements in technological side, from the imaging side, up to the advances that we have in the endoscopes, in the cameras, in the systems of hemostasis. One of the problems in skull base is access. Second is to actually have control of the tumor, the blood supply of the tumor, and early interruption of the blood supply, and therefore the tumor is more safely managed at surgery when we actually deliver it. Now these advances have helped us come together as a team, and the last part of it I would like to also highlight the role of radiotherapy. Now radiotherapists conventionally come into the picture where if the tumor is residual, number one, or in an inaccessible area we have deliberately left behind a small part of the tumor in order to not cause the patient any further deficit or a further neurological complication, or the nature of the tumor. If it is a malignant tumor, then even after surgery there would be an additional need to do this radiotherapy. Now even in radiotherapy there are significant advances, and this Apollo hospital in Bannerghatta Road, Bangalore, has one of the most advanced platforms as far as this radiotherapy is concerned. So it's something called as radiosurgery, wherein the precision, as the name goes, is as precise as surgery itself. So one can deliver radiation using the conventional sources, but the accuracy of that radiation is such that the tumor receives the radiation, but the normal tissues which otherwise would be susceptible to radiation would be spared of the radiation. This is because of the technology platform which is involved in this. We have a technology called as Brain Lab 7D mapping. That means before every delivery of the radiosurgery or radiotherapy, stereotactic radiotherapy system, there is an imaging done. So the imaging is done, it takes into account if there is any patient movement, adjusts the machine, the computer adjusts the machine for that movement, and then the radiation is given. So this is something which is done on an outpatient basis. So comprehensively, the patient, right from the time the diagnosis is made to the discussion in a multidisciplinary team, wherein he would get a very unbiased and a more comprehensive kind of advice as to the course of his treatment, to leading up to surgery. And after surgery, we do have neurosurgical ICU, which is an exclusive ICU for neurosurgery patients, because here the intensivists, the neurointensivists are highly trained and they are very well equipped to deal with neurosurgical problems. And from there, after discharge, the patient, if needed, will move on to the radiosurgery department or the radiotherapy department. So we can then summarize that all these things being available in under one roof is a definite advantage to the patient that we will be able to offer, and therefore we can expect the patients to have a much smoother outcome, much better outcome for these really difficult problems which are rare, but for the patient, when they have this problem, needs to be tackled at an individualized and tailor-made basis for that particular pathology. Thank you.